Hi, this is Elliot Fishman, and welcome to our latest talk, and this is going to be on primary adrenocortical carcinoma. I have given prior talks on CTisus on adrenal masses, be they incidental masses or the differentiation between various adrenal lesions, but this one's really going to focus on primary adrenocortical carcinoma and all the things you need to know and the various appearances and some helpful points in distinguishing it from other tumors. Now, when all is said and done, it's a rare tumor. Depending on the literature you read, it's between 200 and 600 cases in the U.S. yearly, roughly 1 million patients to find one case. Okay, so it's very, very rare. Things that we know, it's more common in females by about 1.3 to 1, though I think it's probably higher than that, maybe 2 or 3 to 1. People talk about a bimodal age distribution in the first decade and later on in the fifth decade. And we'll talk about that, but in my experience, most of the patients we see are in their 30s and 40s, more common in women than men. These articles have spoken about that infants and children under 5 years of age and fourth and fifth decades of life, but again, that under 5, I've seen only a couple cases, so it's pretty rare. When I think about adrenal masses in younger children, I'm thinking about neuroblastoma, so that becomes very important. Also, as we'll speak about, when they occur in female, they're more likely to be functional. It's an uncommon tumor, and interestingly, it's associated with a number of different syndromes. Laframani syndrome, Beckwith-Wiedemann syndrome, Carney complex, congenital adrenal hyperplasia, and MEN1 are some of the things that are spoken about, which really focuses on some of the genetic possibilities with this tumor. There's a lot of research going on trying to figure out how to treat adrenal cortical carcinomas because there is only one drug that works and it's very toxic and has only so-so results. Now, in terms of the use of cross-sectional imaging, like many things, we are picking up earlier tumors, we're picking up incidental tumors, and of course we use this for staging. Now, when you look at adrenal primary tumors, one of the things to think about is they're often functioning. The most common functioning presentation is with Cushing syndrome, typical excess corticosteroid synthesis, obesity is seen, diabetes, hypertension. In females, virilization is also commonly seen, and occasionally you'll have issues on male patients due to estrogen excess as well. But usually it's the female patient. And again, most cases are sporadic, but these different syndromes are kind of interesting because it kind of puts our emphasis in research related to mutations or downregulation of tumor suppressor genes, overexpression of certain growth factors, chromosomal aberrations, and dysregulation of certain important signaling pathways, of all reasons why the patients may get these tumors. So let me just show you the syndromes, which you may not remember, but for the moment you will know. Laframani syndrome, again, multiple different cancers, including a primary adrenal cancer. Carney's complex, which includes cardiac myxomas, testicular tumors, and other neuroendocrine tumors. Beckwith-Wiedemann, I've seen a couple of cases with a congenital disorder with pre- and postnatal overgrowth, abdominal wall defects. Familial polyposis, you think more about colon cancer or cancer stomach or small bowel, but adrenal cortical carcinomas are one of the things. And then MEN type 1, we think about the pituitary and parathyroid and pancreas. You forget about the adrenal, but adrenal cortical carcinomas are rare, but they can occur with increased frequency. If you look at the spectrum of patients, typically people will say 60% or 40 to 60% are hormonal presentation, flank pain or back pain about 30%, and incidental finding up to 15%. Now, flank or back pain typically means the tumor is larger, it's spread, and the patient has direct extension locally. So the patients who are lucky, if you can use the word lucky, might be incidental findings or with hormonal abnormalities. When you present with Cushing's early, you make the diagnosis, the tumors are often 3 or 4 centimeters. Those are the patients that do really well. When you have back pain, it's probably 10 to 15 centimeters, and you're not going to do so well. We talk about the CT appearance, and I'm going to show you many different images. In terms of non-contrast CT, usually over 20 Hounsfield units, and it enhances depending on the vascularity of the lesion, but most lesions have some vascularity, but they're not homogeneous. Tumor size, 2 centimeters or 3 centimeters. Remember I mentioned the functioning, up to 20 centimeters or so on the non-functioning. And of course, survival depends on local spread of disease. This idea about incidental findings is kind of interesting. We see incidental adenomas all the time. We talk about 7 to 10% of patients, increased incidence in older patients, females, patients with obesity. But primary adrenal carcinoma is something you need to think about as well, though I will have to admit, although the numbers seem relatively high, my experience is not that high. And again, this article does make the point, when you think about adrenal lesions, you always have to be careful that you can't rule out a primary adrenal cortical carcinoma just by size, because if you're picking up an incidental finding, maybe you lucked out and it's 2 centimeters or 3 centimeters. So again, and we know size alone is not a great criteria for benign or malignant, though we do know if something's under 3 centimeters, statistically it's going to be benign, but it depends on its appearance and depends on its enhancement. Roughly 70% of tumors are over 6 centimeters. Again, we talk about a range of up to 20 centimeters. Modeled enhancement pattern, the lesions typically are vascular, but there's areas of necrosis. We talk also about areas of fat occasionally, though I find that very rare. More commonly, I'm going to talk about the presence of calcification. We talk about the varied enhancement pattern, the apparent capsule versus infiltration of the borders. There's no doubt when there's no well-defined lesion, that is really a more aggressive tumor and means local spread, which means the patient, even with surgery, is going to do poorly. When you have invasion of the periadrenal fat and surrounding organs, that's obviously malignant, but that's going to be a high-grade malignancy. And obviously vascular involvement, be it renal vein or IVC, or distant mets to lung or to liver, are going to be very problematic. We mentioned microscopic fat, and again, when I see fat, I think about a myelolipoma. The primary adrenal cortical carcinomas that I see with fat are large and they're ugly looking. They have calcification, they have extensive enhancement. You know they're bad tumors. I think some of it is direct invasion of the perirenal fat or periadrenal fat, but again, it's something at least to think about. If you see fat in a tumor, at least I give it a thought. Now you remember neuroblastomas also contain fat, but I don't think it's going to be a problem in the differential diagnosis. Now calcification can be seen in up to 30% of cases. It's often coarse and central. We can see calcification in pheochromocytomas. We can see calcifications occasionally, but rarely in adenomas. Not uncommonly, you can see them with small adrenals, like a patient who's had TB. You could also see calcifications either central or rim-like in patients who've had prior hematomas. We talk about the presence of nodes. When tumors spread, it's local nodes, lung, liver, and bone. And the lung, liver, or bone can be the initial presentation. The majority of lesions are going to be non-functioning in adults. Again, as we mentioned, the non-functioning tumors are the ones that often present with mass effect, and they're larger. That's just the way it goes. If you pick up lesions incidentally or hormonal abnormalities, they're going to tend to be smaller. In terms of children, again, I mentioned we rarely see it in children. When it is in children, functioning tumors are going to be more common than in adults. In adults with functioning tumors, 30% are Cushing's, 20% virilization, and between 10 and 20% a combination of the two. Feminization and hyperaldosteronism are much rarer, each accounting for about 2% of ACC cases. Now, just some things to remind you of. Cushing's does not mean you have a primary adrenal cortical carcinoma. It could be an adenoma. It could be a pheo. It could be PPNAD or macronodular hyperplasia. Similarly, in Conn syndrome, the majority of patients are going to have adenomas. It's only 1% that has a carcinoma, but it's something you need to consider. And of course, adrenal hyperplasia is another cause. When we talk about Cushing syndrome, we talk about the elevated cortisol levels. Cushing syndrome can result from exogenous administration of glucocorticosteroids or endogenous overproduction. The triggered pathway of Cushing syndrome can be divided into pituitary-dependent and pituitary-independent. Females are more likely to have Cushing's than males. It's most commonly caused by adenomas, but also carcinomas and pheochromocytomas. And again, as we said with Conn's, autonomous aldosterone production causing sodium retention, plasma renin suppression, hypertension, cardiovascular damage, and leads to varying degrees of hypokalemia. Again, adenomas are most common, but carcinomas occasionally. We talk about Addison's disease, primary adrenal insufficiency. Again, most of the time we see that it's from infection or bilateral hemorrhage, metastasis, but remember, to get Addison's disease, you need to have bilateral adrenal involvement. If you have one functioning adrenal, you're fine. So it's going to be pretty rare with primary adrenocortical carcinoma, though it is reported. And here's just the list again: autoimmune adrenalitis, TB, tumors, infection, hemorrhage, and certain HIV conditions are all possibilities. Now, one thing to also comment on, typically CT is the diagnostic tool. Occasionally we will use MR. Often that's for staging for vascular involvement if case CT is indeterminate. PET can be very helpful. PET has a high sensitivity and specificity for identifying malignant adrenal masses. It can't separate in most cases METs from primary tumor. And also, at times, it will not be as specific because other lesions, again, can have increased uptake on PET. But it can be helpful, particularly for looking at spread of disease. There are some markers in this article by Ahmed. Ki-67 is among the most important markers in differentiating benign from malignant adrenal lesions. Lesions with a Ki-67 index of over 5% are likely malignant. So that can be very, very helpful. And as we go to more information in medicine, going both on the clinical side, the lab side, and the radiology side, this Ki-67 is going to become very important. It also notes that tumors with less than 10% Ki-67 have better outcomes than those with greater than 10%. So you can see a lot of these markers, this whole area of genomics is becoming incredibly important in patient care, but incredibly important in radiology. If you have stage 4 disease with adrenocortical carcinoma presentation, your survival is less than 3 months. There is mitotane, which is a drug that can be used, very toxic. Sometimes it helps and increases survival. The overall 5-year survival for patients with ACC is 38%. Local recurrence, lung, liver, bone are all possibilities. But again, it's really the low-grade tumors where the patients do better. High-grade tumors, the patients are going to do very poorly very quickly. When patients do have adrenocortical carcinoma, even if the margins are negative and nodes are negative, close follow-up, CT or MR every 3 months for the first 2 years, and then careful monitoring of steroid levels, and then after 2 years, follow-ups every 6 months. And again, about 90% of cases recur during the first 5 years after resection, so there really is no clear recommendation after 5 years. Our experience is yearly follow-up. So when you talk about primary adrenal carcinoma, what could it be? You see a big adrenal mass, and I'll talk about this a bit later in more detail with examples, but you could have an adenoma. It could be a pheo. Pheos can enhance very vigorously and can be very large. Lymphoma, less vascular than most primary adrenocortical carcinomas. They can be solitary, like one side, or bilateral. When the bilateral, it's easy, but they can be unilateral and big. Again, makes you think of primary adrenal carcinoma. METs, think about vascular METs like renal cell. Ganglioneuroma and neuroblastoma are all possibilities. There are a number of different mimics, and we also spoke about adrenal hemorrhage and pseudocyst and adrenal hemangioma, which is rare but can be somewhat problematic because it is vascular, and adrenal hemangioma can often at times be confused with a pheochromocytoma. It's interesting, when I look back, we've written about adrenocortical carcinoma. This was an article from 1987, way back when, some very famous co-authors there, when we spoke about adrenocortical carcinoma in 38 patients. That was pretty impressive way back when. And then a more recent article, 2009. So let's look at some of the things we learned in those articles, but also we've learned since then. Again, primary adrenocortical carcinomas are large. There's areas of necrosis. There's variable enhancement. We see calcification commonly. But again, the tumors are not going to be confused with benign lesions. I think it's very important. Every once in a while, you'll see a small adrenocortical carcinoma that doesn't have a lot of enhancement. And you begin to wonder, what could this be? But typically it's not going to be a problem. Now, there are some things that can simulate ACCs, but we'll talk about them later. Now, one of the things with adrenocortical carcinomas is invasion of the IVC, renal vein into IVC. These patients typically have more aggressive tumors. Obviously, will often have increased spread of tumors. We also note that it's more common to have right-sided tumors invading the IVC, which makes sense because the right renal vein is shorter than the left. We talk about extension into the IVC, up into the liver IVC, and then into the right atrium. Adrenal carcinomas have heterogeneous enhancement with necrosis, calcifications, and hemorrhage. This article by Albano makes the point about hemorrhage. Occasionally, primary adrenocortical carcinomas can present with hemorrhage, that it is often one of its presentations, and I'll share a couple examples, but they can have hemorrhage. But again, this modeled enhancement, this irregular enhancement is indeed very important. And things we look for: involvement with local organs, be it the kidney, the IVC, on the left side, the spleen or splenic vessels, as well as looking for nodes or liver metastasis. So some examples. Here's a case which makes one point that I'll reinforce later. At times when you look at this image, only at this image, it looks like maybe this is a primary liver lesion like a hepatoma. Hepatomas can be well defined with pseudocapsule, but this is adrenal lesion, as I'll show you. You see the necrosis, you see the large size, you see the central calcifications, you see the mottled enhancement, you see some nodes more medially placed. You can see the tumor is very necrotic. You see the neovascularity. There's not much of a differential as long as you don't make the mistake of calling this a liver lesion, but I think once you've seen them, you kind of know the interface between adrenal and liver. The coronal views, the 3D in this case, is very valuable. You can see the mass pushing on the patient's renal artery. These tumors often simply compress the upper pole of the kidney even when they're very large, but occasionally they will invade, so you need to look at that carefully. And you can see the necrosis and enhancement. Primary adrenocortical carcinoma. No ifs, ands, buts, or maybes. We've looked at this also with cinematic rendering. Very nice example of tumor necrosis, solitary areas of calcification. You can see the various enhancement. The red tends to be necrosis. The more white, more vascular areas. Very nicely seen as we look at the various rendering parameters of primary adrenocortical carcinoma. Another example, very similar, right? Central necrosis, calcification. Here the patient has a lot more nodes and collateral vessels because there's vascular invasion. The nodes are often very vascular, as in this case. Again, you see the pushing of the tumor. Sometimes on right-sided tumor, it's hard to tell IVC involvement because the IVC is compressed rather than invaded and there's so much tumor present. So it can be a bit tricky. Coronal views are especially helpful. And of course, looking at these tumors as well beyond coronal views can be very valuable also. So that becomes very, very important. So it's something we need to look at carefully. And here again, extensive necrosis by the patient's tumor. And again, another set of images. You can see there's no distant nodes, but there are local nodes present. Again, another example showing you the cinematic rendering picture. It kind of looks classic, that central necrosis, the calcification, the solid components around the periphery of the lesion, the size of the lesion, the growth up to the diaphragm, the way it pushes the kidneys down, are all really good signatures of primary adrenocortical carcinoma. And I'm showing you a number of different images, as I promised in the beginning, because I think it's very valuable to see this information. Now, this patient presented with right upper quadrant pain, and there's a mass in the region of the adrenal. Now, there's bleeding present. That's why the patient presented. Now, what can bleed? Obviously, adrenal post-trauma. Pheochromocytomas can bleed, but primary adrenocortical carcinomas can bleed, as well as metastasis. I think once things bleed, it's hard to judge how large they are, because some of it is just the bleed. Invariably, this was mass-like, this was resected, and was a primary adrenal carcinoma. So again, Mets, particularly lung cancer, can present with bleeds. And the patients often present with right upper quadrant pain, and the rec says, rule out acute cholecystitis, rule out pancreatitis, and you find this adrenal lesion. Now, in terms of spread, a large necrotic tumor, right adrenal gland. You see the liver mets. The liver mets are vascular, and that's common. You see the lung metastasis, often small and multiple. Again, you can look at these images, the vascularity of the metastasis to the liver. There are multiple large and small metastases present. And here it is again, the really extensive liver involvement, particularly the left lobe, as well as the patient's primary tumor. So again, you need to be very careful when you stage these tumors to do dual phase imaging, because often the lesions are only seen in arterial phase or best seen in arterial phase. Now, obviously, a case like this with so many liver lesions is probably not going to matter, but some cases have solitary lesions, and then it could indeed be very critical. Again, showing you the tumor necrosis, and you can see from these first 3 or 4 cases how things look very similar. We're on the right side. Here's the venous phase imaging. You can see the liver lesions are still seen, but not as well seen, and they wash out. But again, no great difficulty in making the diagnosis. And again, looking at the venous, looking at the necrosis, and again, you would wonder, looking simply at this lesion, could it be liver? And again, it's a pitfall, but it's something you should not make the mistake when you look at all of the images. And again, use the coronals, the 3Ds. Sagittal views can also be very helpful. Here's another patient, right upper quadrant pain. There's a bleed in the adrenal bed. There was no other symptoms or history. This was resected. It got a little smaller with time, but people were concerned there was an underlying mass. Again, there was no known primary. This was a primary adrenal carcinoma. So again, when I think about bleeding, I'm going to think about primary adrenal cortical carcinoma. Here's some more pictures showing you the acute bleed. Again, presentation is unique. Remember, we also talk about spontaneous renal bleeds. That could be underlying renal cell. It could be an AV malformation. It could be an angiomyolipoma. There are a lot of different possibilities. Something to think about. Obviously, trauma or biopsy are other causes as well, but this is very nicely shown in this example. Now, in terms of incidental findings, I guess this would be considered an incidental adrenal carcinoma. This patient had ulcerative colitis and had been having bleeding, and we were looking for any site of bleeding, and you see a left adrenal mass with calcification. It's large, it's somewhat necrotic, and it wasn't there a year before. This was a primary adrenal cortical carcinoma that one could say is an incidental finding, because we were not scanning the patient for Cushing's or Addison's disease or flank pain. We were looking for GI bleeding in a patient with known ulcerative colitis, and you can see the diseased left colon, but this was a primary tumor. Again, just to show you an example with the coronals and the cinematic. Again, the central necrosis. In this case, what looks like a well-defined capsule. And you can see as I change the rendering parameters, we can really bring out that information and show it very nicely. One thing to also comment, adrenal cortical carcinomas can sometimes be very cystic. Here you can think about a cyst or old hemorrhage. When you go down, the wall is somewhat enhancing, it's definable, and you look hard on the lower portions, you see more solid components. So you knew it had to be a malignancy. Maybe it was a cyst with malignancy, which is really rare in the kidney. It's exceedingly rare in the adrenal. But again, a large mass cystic with solid component, primary adrenal cortical carcinoma. But it does make the point that these lesions can be cystic. We also speak about other cystic large lesions like pheochromocytomas. Another example, non-contrast CT. You can see that not every adrenal lesion enhances to any degree. Large mass, there's minimal enhancement on this very large tumor, but based on size, you have to worry about malignancy. As you go from arterial to venous, perhaps there's a little bit better enhancement, but you can see there's not great enhancement. Again, a large mass, lobular, irregular margins, you got to be thinking ACC. You don't necessarily need to see a vascular lesion, and this case I thought was a good example of showing you that. And here's the texture mapping with cinematic rendering, and I think that's very, very nicely shown in this example. Now, when we talk about adrenal carcinoma, we talk about staging, and I think what I'm going to do is let's pick up the staging when we talk about vascular involvement in a few moments. Let's bring that back as part 2, and let's stop here. Let's get a cup of coffee, and we'll come right back. Thanks very much.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.